So in the last few minutes, I'll just go through another case. This was a case I saw, I think, about 7 years ago here in LA. It's a 4-year-old Asian male who initially presented with developmental delay at age 5 months, was evaluated by neurology for seizures, and the EEG did show that the patient had persistent seizures and had slightly decreased volume on a brain MRI. Clinical history, 2.5 years later, the patient developed generalized edema. The urine protein to creatinine ratio was 16. A urinalysis was devoid of any red blood cells. Albumin was low at 1.5. Patient was started on prednisone, a standard dose of 2 milligrams per kilogram per day, had no response after 2 months of treatment. The creatinine was a little bit high for age at 0.7. No significant past medical history, no consanguinity. The father's cousin did have a history of epilepsy, but no history of kidney disorders. Patient is not on any chronic medications at the time of the generalized edema starting. So the patient was biopsied, and it showed extensive foot process effacement by EM. 20% was completely sclerotic in the glomeruli, and there was partial consolidation of a capillary tuft and prominence of overlying glomerular epithelial cells and some adhesions. So we ended up doing genetic testing with whole exome sequencing, and we did Sanger sequencing for confirmation and found the patient had a new novel mutation, a nonsense de novo heterozygous mutation identified in TRIM8, which was disease-causing and caused the patient to have both seizures, developmental delay, and nephrotic syndrome. So the lessons learned from this case, knowing the genetic cause can really help with prognosis and genetic counseling. The parents wanted to know the likelihood that this gene would be passed along to any future children that they would have. Transplant disease risk, the patient actually is now transplanted and the disease has not recurred, most likely because he does have a genetic mutation. And we were able to really avoid immunosuppressive agents, which, as we know, have a lot of different side effects associated with them in this patient. So genetic testing can also lead to advancement of research and our understanding of nephrotic syndrome and other kidney diseases. So conclusion, there is a good proportion of kidney diseases that have a monogenic kidney mutation. It's much higher in pediatrics than in adults, but it's still important, I think, for the adult population to undergo genetic testing for the reasons I've outlined in the past. It can lead to disease reclassification. It's important for future family planning and for transplant outcomes, and also to monitor for extrarenal manifestations.